Paediatric Ophthalmology Society session. We have 4 excellent international speakers for you today. The first being Dr. Yongmin Huang, Dr. Chen Zhao, Professor Rita Sitorius, and I'll be your final speaker. Can I please invite Dr. Yongmin Huang to give her presentation entitled A Long Journey to the Better Management of Exotropia. Thank you.
Thank you, Dr. Kat. Good afternoon, colleagues. I appreciate the organizing committee for the invitation. I am Jungmin Hwang from Korea. I'd like to share my story of a long journey to the better management of exotropia with you. I have no financial disclosure. Before we get to the point, I'd like to tell you this. There are parents who say my child's one eye sometimes turns outward. However, there was no exotropia with repeated alternate occlusion. Never say there is no intermittent exotropia. If you ask the parents to bring a photo next time, you can get a photo like this. Parents are always right when they say their child's one eye drifts outward or up. Management exotropia includes non-surgical treatments such as correction of refractive errors, over minus, prism glasses, part-time occlusion, and surgeries. Correction of refractive errors, especially myopia and anisometropia, as well as occlusion for amblyopia, are the primary step to manage exotropia. Sometimes myopic correction can improve intermittent exotropia to exophoria. Myopic correction is so important for the management of intermittent exotropia. Minus lens can stimulate accommodative convergence, thus reduce the angle of exotropia. Fusional convergence to control exotropia induces distance blur. Over minus lens may allow clear distance vision, thus facilitate fusion. Pediatric Eye Disease Investigator Group, PEDIC, found that over minus lens improved distance control in 3 to 6 years of age with intermittent exotropia. Part-time occlusion decreases suppression and improves fusion, thus decrease the angle of deviation. A PEDIC study reported lower deterioration rate with part-time patching in 3 to 10 years of age, but observation was also reasonable. Another PEDIC study found no difference between patching and observation in less than 3 years of age. Let's move on to surgeries. First of all, when can we say exotropia surgery is successful? Dr. Rosenbaum reported that 60% underwent reoperation up to 31 years after surgery, mostly for recurrence. Therefore, it is hard to say that exotropia surgery is successful anytime. In my cohort, median time from surgery to recurrence was about 4 years. Surgeries for exotropia could differ according to the type of exotropia. RNR or BRR recession for basic type exotropia, BRR recession for true divergence success, and RNR for convergence insufficiency type exotropia are usually recommended. In basic type exotropia, 3 out of 4 randomized control studies, first by Dr. Kushner, followed by Dr. Zomo and Dr. Zhang, showed that RNR was better than BRR recession. Fourth RCT by PEDIC showed comparable results between RNR and BRR recession. In convergence insufficiency type exotropia, lateral rectus recession based on distance deviation and medial rectus resection based on near deviation can be successful. Now I will talk about my tips to improve the surgical outcome of exotropia in 3 steps: pre, intra, and post-op management. First of all, a longer time may be required to reveal near deviation. I take enough time for near angle measurements. Preoperative monocular occlusion increased near deviation angle, especially in hyperops and divergence excess type exotropia. Monocular occlusion may be helpful to reveal true near deviation angle. In addition, near distance angle difference could change after monocular occlusion up to 63%. What would be the target angle when measured angles are so variable? I would suggest targeting the largest angle ever measured. We evaluate the result of BRR recession for the largest angle ever measured. At the last follow-up, there was no overcorrection at distance, and only 6% showed issue deviation less than 10 prism diopters and near. To reduce recurrence rate, we have been increasing the surgical dose. Augmented BRR recession by 1 to 1.5 mm showed higher long-term success rates and lower recurrence rates, especially in divergence excess type. Overcorrection rates were similar. Augmented RNR with medial rectus resection increased by 1 mm showed lower recurrence rates. Overcorrection rate was not significantly different. Augmented RNR can be considered in basic and convergence insufficiency type exotropia. Intraoperative force reduction test could help you decide which eye to operate in RNR. RNR performed on the eye with a tighter lateral rectus muscle on intraoperative force reduction test resulted in lower recurrence and reoperation rate. Intraoperative force reduction test might be considered when planning RNR in intermittent exotropia. In summary, augmented BRR recession, augmented RNR, and RNR according to intraoperative force reduction test could achieve lower recurrence rate. However, we should be prepared for overcorrection. In the early post-op period, I tried to maintain the eye that had undergone RNR in the primary position by occluding the unoperated fellow eye. If consecutive esotropia persists, prism glasses are helpful to maintain fusion. In esotropia after RNR, when fitted with prism glasses, a successful motor outcome was achieved in 71%. No patient demonstrated new onset amblyopia. Less than 1% lost stereo acuity. In esotropia after BRR recession, when fitted with prism glasses, successful motor outcome was achieved in 67%. No patient lost stereo acuity as a result of overcorrection. Finally, botulinum toxin injection could be useful for consecutive esotropia. Even without EMG guidance, botulinum toxin injection into the medial rectus could achieve successful alignment in 69%, especially if with overcorrection of 18 prism diopters or less at post-op 1 month. In summary, prism glasses, either after RNR or BRR, as well as botulinum toxin injection, can be useful for overcorrection. In conclusion, surgery for exotropia could differ according to the type of exotropia, RNR or BRR for basic type, BRR recession for true divergent success, and RNR for convergence insufficiency can be successful. Last of all, you'd better take enough time for near angle measurement and target the largest angle ever measured. Consider augmenting the surgical dose and performing the first action test to find a tighter lateral rectus. Postoperatively, occlude the fellow eye of RNR and use base-out prism glasses for overcorrection with careful weaning. Dhanyabad. Thank you for listening.
Thank you very much. Thank you very much for that presentation. If I could just make a comment to our listeners, we will have time for questions at the end. So we'll have all the speakers give their presentations and then we can answer questions at the end. Please feel free to put your questions into the question box you have available to you. Our second speaker today is Dr. Chen Zhao, who's speaking on the management of triad exotropia with one-step triple surgery. Thank you very much, Dr. Zhao. Dr. Zhao, you might be on mute, I think.
Oh yeah, can you hear me now?
I can, thank you.
Okay, all right, sorry, yeah. Okay, so I'll be talking about the management of triad exotropia with one-step triple surgery. So just a little bit of background about the syndrome. Triad exotropia is also called as Helvesen syndrome because it was first reported by Dr. Helvesen in 1969. Although the etiology of the disease is still unknown, but the clinical features of this disease are very clear, including A-pattern exotropia, bilateral superior oblique overreaction, and dissociated vertical deviation. And some patients may do not present DVD, but instead presenting alternating hypertropia. So this syndrome is relatively complex, but not rare in the clinic. And we believe that among the three features, bilateral superior oblique overreaction is a key feature because the A-pattern strabismus and the torsional chain of fundus are both associated with superior oblique overreaction. And because of superior oblique overreaction, DVD in those patients are often asymmetric and concomitant, meaning that the magnitude of DVD is much larger when the non-fixed eye in AB duction than in AD duction, as you can see in this diagram. And other clinical features of the syndrome, including nystagmus in roughly 20% of those patients. Most patients are bilateral involved with amblyopia and nearly no stereopsis. So for the surgical treatment of this disease, theoretically, each single of the characteristic dysfunctions should be corrected. So the superior oblique should be weakened, and there have been many options on this regard, including a new procedure that we recently developed. I'm going to give you more detail about this procedure later on. And BSR should be weakened to minimize DVD, and BLR should be weakened to correct the exotropia. So if we do all those muscles together, it's called one-step triple surgery. So this is a theoretical design. But in real practice, the phenotypic diversity among those patients may require different surgical approaches. So the angle of horizontal deviation, the size of A pattern, the magnitude of DVD, and so on are all important factors to be considered for the appropriate selection of procedure. And I think the first question is, should we do a one-stage or two-stage procedure? Because traditionally, some famous doctors recommend to correct vertical misalignment in the first stage, and then wait for a couple months, and then do second operations to correct horizontal deviations, because they realize that the correction of vertical DVD and A pattern will significantly affect the horizontal deviation. But nowadays, more and more doctors will do one-step triple surgery because it's obviously time and the cost saving. But if we do one-step surgery, there will be some further specific question to be answered. Like we have to know how the weakening of superior oblique and superior rectus together will affect horizontal deviation, especially in a long-term follow-up. And what is a key factor to that attribute to the horizontal shape. And if we know these answers, we may know how to avoid such changes, and we may know how to be the target angle for the correction of horizontal deviation. So to answer these questions, we did a retrospective study. We made a comparison between two groups. One group of patients with triad exotropia and another group of patients with constant exotropia. And the inclusion criteria of those patients is that for all patients with triad exotropia, they must have received one-step triple surgery. And for patients with constant exotropia, they must have received BLR resection. And every patient has to be followed up for more than a year, and all operations were done by myself. And for those patients who had previous strabismus surgery or any cranial nerve palsy, they were excluded from this study. And for each patient, we did at least 3 time course examinations before the operation, 1 month after operation, and the final visit should be longer than a year after the operation. And at each time, our data collection, including BCVA, the sensor monitor evaluation, the size of A pattern, the grade of superior oblique overreaction, the magnitude of DVD, and so on and so forth. And in this study, we end up having 15 patients with triad exotropia and 39 patients with constant exotropia. And the numbers are not big because my clinic, 90% patients are from other provinces. So it's very hard to have them come over after a year, 1 year after the operation. But still, the numbers are good enough to make a favorable comparison between the two groups. As you can see here, the two groups are comparable in terms of the amount of horizontal deviation and in terms of the amount of AR recession. And as I mentioned before, for the patients with triad exotropia, we did one-step triple surgery. So we weakened bilateral superior oblique using a new approach that we recently developed. We call this a temporal superior oblique suture lessening. So as you can see here, we use a non-absorbable suture to pass through the tendon of superior oblique. We tied the sutures, leaving a certain length. So the length of suture is based on the grade of superior oblique. For instance, if the superior oblique is graded at +3, we then leave 6 to 8 milliliters of the suture, and then we cut off the tendon of superior oblique, and then the two ends of superior oblique are connected by this suture. So it's a simple and semi-quantitative procedure for superior oblique weakening. And if you need more detail, you may want to visit our paper published last year in EJO. And here is the result. At 1 month after operation, both groups showed a relatively good result. None of the patients showed overcorrection, and most patients had a small angle of exotropia that is less than 6 prism diopter. But at 1 year or longer after this operation, the two groups, as you can see here, went to opposite directions. So the patients with triad exotropia showed significant ESO drift of 7.7 prism diopter. But another group, the constant exotropia patients, showed axial drift of 3.5 prism diopter at final visit. And here you can have a more clear picture. As you can see here, at final visit, 13 out of 15 patients with triad exotropia had ESO deviation. Please remember that most of those patients still had minor exotropia at 1 month after the operation. But on the contrast, another group, 95% of patients with constant exotropia eventually showed axial drift at the final visit, as you can see here. So the difference between the two groups tells us that the weakening of superior oblique and superior rectus together will cause ESO drift. And now the question is, what is the factor that attributes to this ESO drift? So to answer this question, we did multiple linear regression analysis, and we analyzed a lot of factors, including the angle of horizontal deviation before and 1 month after surgery, the size of A pattern at each time point, and the total reduction of A pattern, the magnitude of DVD at each time point, and total reduction of DVD, the function of superior oblique at each time point, and the total reduction of superior oblique overreaction, and so on. And among those factors, we finally found out that post-operational function of superior oblique is the only factor associated with ESO drift. As you can see here, the p-value is 0.011. And here you can see that those patients with superior oblique underreaction at final visit showed a much larger ESO drift compared with those patients without superior oblique underreaction. There's a t-test between the two subgroups. So thinking about the reason of ESO drift, our result actually makes sense because we did BLR recession for those patients using a regular table. See if the patients have 25 prism diopter at distance, we then do BLR recession of 6 milliliter. So the regular BLR recession will not cause ESO drift in so many cases, right? And BSR recession will actually cause potential axial drift because this procedure will reduce the adduction ability of superior rectus. And only the weakening of superior oblique will cause potential ESO drift because this surgery will reduce the abduction ability of superior oblique. We also did some literature searching, and we found our results are consistent with most previous studies. We found at least 3 previous reports demonstrated that a weakening of superior oblique alone will cause ESO drift at a variable degree. And now back to our original question list. And now we know that weakening of superior oblique and the superior rectus together will cause ESO drift in one-step triple surgery. And the post-operational underreaction of superior oblique is a key factor attribute to this ESO drift. And how to avoid such changes and what should be target angle for the correction in this one-step triple surgery? I think 2 things we may want to consider. One, we may want to target a small angle of undercorrection of exotropia in this one-step triple surgery. And the second, we really want to avoid superior oblique underreaction after the surgery. So we may want to use some semi-quantitative procedure for superior oblique weakening procedure. And in this study, I actually also analyzed correction of vertical misalignment, but I don't have enough time to go through all this data. But I can tell you that our one-step triple surgery has been very effective to correct the size of A pattern, the magnitude of ADVD, also to restore the intorsional change of the fundus. And also, we realized the limitations of our study, like the small sample size, like it's a retrospective study in nature. But I do hope our study can provide some new insight in the field. And finally, I'd like to start by acknowledging all my team members, and in particular, I'd like to acknowledge two doctors, Dr. Wu and Dr. Xia, who have contributed to data collection in this study. And with that, I'm ready to take your questions at the end. Thank you very much.
Thank you very much, Dr. Zhao. So it's been two very, very interesting talks on exotropia. Thanks very much. Our third speaker is Professor Rita Sito, and she's presenting on a topic entitled "My Baby Does Not Look at Me, What to Consider." Thank you very much.
Thank you, moderator. Today my topic would be a very practical issue. My baby doesn't look at me, what to consider. So, yes. We know that the baby's visual system are not fully developed at birth, but it will be improved over the time. So the immaturity of the neuron system at the level of eye to the brain will be the cause of the immaturity of the visual system. So we have to know, or we should know about the normal human visual development to deal with the problem. So the function for visual fixation present at birth, and the function of this fixation will be well developed at the age of 6-9 weeks. The visual following will well develop at age 2 to 3 months. So if the process does not develop normally, but it will lead to impaired visual function. So the mother will come to us and with the complaining of why my baby doesn't look at me, or why my baby do not respond to the object given. So investigating poor vision in children, including steps, some important steps. The first is to take the relevant history. Which data should we ask? First is birth history, including premature baby. If it is premature, how is the birth weight, gestational age? Is there any adverse perinatal problems, developmental milestone, etc.? And then information about the pregnancy, how was the delivery, postnatal development. The presence of seizure, developmental delay, and dysmorphic feature will lead to a potential brain problem as the cause. And we can consider hereditary eye disease if in a family history we find positive family history or consanguinity. Another history that's important to take is the presence of photophobia. But of course, this information quite difficult to ask, especially in very young babies. So another information we should ask is there any wobbling eyes? Is there any specific hand movement? So in principle, the history taking should be in detail and doing very carefully. After taking the history, we perform the eye and systemic examination. As a pediatric ophthalmology, the simple test for checking the visual acuity is to do fixation and following test. We can use pen light and then object. As you may see in this video, the normal full-term baby should respond to visual fixation and following respond to the light and to the object at the age of 2 to 3 months. I believe that everybody already familiar with this simple procedure. And in the eye examination, we should check for the nystagmus, absence of presence, the alignment, the eye movement, how is the pupillary response, and how is the ocular examination, both in anterior, either in anterior segment or posterior segment. Oftenly, we need to work up to the ancillary tests, such as laboratory tests, serological tests for TORS, ultrasound, electrophysiological tests, and imaging, MRI or CT scan. And the important also to work with the other disciplinary subspecialty. So make a multidisciplinary consultation to get a perfect diagnosis. I'd like to share with you 3 cases that admitted to us to come to me with where the mother complained with that their baby doesn't respond to the object that was given. So the first case is a boy aged 13 months referred from a remote hospital that the mother complained that the baby does not respond to the stimulus given. He is a premature baby, gestational age 28 week, birth weight 1,040 grams, and stay at the incubator for 2 weeks. There is a note that he has global delay development, fixation and following light task showing pull for the object negative, and there was also nystagmus, corneal opacity on both eyes, shallow anterior chamber, fundus not visible. Sorry that I cannot show you the corneal opacity and shallow anterior chamber. And then because fundus not visible, then we perform ultrasound. This is the ultrasound looks like. We can see here that there was opacity on the vitreous, and in some part there is a retinal detachment. So we consulted the pediatric department, and they conclude with the global motoric disorder. So what is the diagnosis? It's easy because this is premature, and then conclude from the clinical data. This is ROP stage 5, both eye with global motoric disorder, which lead to the unresponsive to the stimulus given. And the case 2. The case 2 is a boy aged 6 months, does not respond to an object noticed at age 2 to 3 months. He is the full-term baby, birth, no perinatal complication, with normal motoric development. He was born as a consanguineous married with a brother affected with Dandy-Walker syndrome. But Dandy-Walker syndrome is a genesis or hypoplasia of the paramis and cystic enlargement of the fourth ventricle. We check for the fixation following light object showing poor response. There was nystagmus, but the anterior segment was normal and the fundus relatively normal. This is the picture. Normal segment, anterior segment, a relatively normal fundus. We perform the electrophysiology, ERG showing non-detectable rod and cone response. Because the brother suffer for Dandy-Walker syndrome, then we took brain MRI, but the result is normal structure, no lesion, no immediate infarct as the brother has. So the question is, does not respond to object, nystagmus, normal anterior segment, relative normal fundus, the non-detectable RG, and VEP normal. What was the diagnosis? So the diagnosis would be that we define is inherited retinal dystrophy, cone-rod or rod cone dystrophy. Dandy-Walker syndrome in the brother could be incidental finding or associated with the retinal dystrophy. But unfortunately, genetic testing to prove that is not available yet. We look at the case 3, a boy aged 4 months. Child does not respond to lights and objects. He was premature baby, gestational age 30 week, birth weight 1,800 grams, normal delivery with the respiratory distress, use ventilator at NICU, presence of seizure, history of presence of seizure, the pedigree, no family history, no consanguinity marriage of the mother, of the parents, and he also has microcephaly there. So because he's premature 4-month poor vision, we thought, is this delayed visual maturation or ROP? or we have other diagnoses. What do you think? This is ophthalmological examination that we perform, fixation and following tests not respond to light and or object, no clear nystagmus, orthophoria, normal anterior segment, and the fundus. We check for the fundus. This is the fundus looks like. Pale optic nerve head. On the both eyes, there are retinal exudate and vascular sheathing. On the left eye, this is frosted branch and retinal hemorrhages. And we work up again in the laboratory and multidisciplinary consultation. What we found at the serologic test showing anti-CMV, IgG and IgM reactive. And cranial ultrasound, we found bilateral ventriculomegaly and vasculitis in bilateral ganglia basalis. We took the vitreous with vitreous tap and sent it to the laboratory showing positive CMV on the PCR. So what is the diagnosis? The diagnosis is CMV retinitis, congenital CMV infection, and he was treated by the pediatrician with anti-CMV agents. So this is algorithm investigating poor vision in children. Sorry, this is very busy slide, but briefly, what we need to check is first, as a preferable subject, check for the poor visual acuity, Is it normal or abnormal? And then check for each part of the eyeball, cornea, lens, optic nerve, retinal vitreous, whether this is abnormal or normal, and then follows the procedure on detail according to the abnormality of the part that we found. In normal and abnormal, here as we can see in abnormal visual acuity and normal eye exam, we can check for electrovisuology, MRI, etc. So what is the lesson learned? Poor vision in children may result from many disorders, congenital or acquired problem. A comprehensive and systemic ocular and systemic evaluation is very important, is required. Some cases might be challenging to diagnosis. Importantly, is multidisciplinary approach is often required. Thank you.
Thank you very much, Professor Sito. There's some very illuminating cases there. Thank you. I'm your final speaker today. I'm just going to get my slides up. And share my screen. Terrific. So thank you very much for the invitation to speak. It's my very great pleasure to be talking from Sydney, Australia this Sunday evening on the topic of herpes simplex keratitis in children. As you know, herpes simplex virus keratitis is a common and visually disabling condition affecting both adults and children. But children are particularly at high risk for visual morbidity because there are unique challenges in making the diagnosis and also the treatment. And they often experience a more aggressive disease course that results in corneal scarring and amblyopia. It's a really important differential diagnosis to keep in your list for any child presenting with keratitis. HSV is contracted when there is direct contact with active lesions or secretions. The virus then replicates in mucosa or skin and it spreads via peripheral nerves to the trigeminal ganglion. There it becomes latent and then under certain conditions will reactivate, causing recurrent episodes of ocular inflammation. It's a very common condition. If you check for HSV 1 and 2 across adult and children populations, up to 90% of individuals can be affected. And humans are the only known natural reservoir. Seroprevalence is believed to be related to the degree of exposure, so it's more common in conditions of crowding and poor hygiene and in a young age. Neonatal HSV is contracted when there is active shedding of virus particles from the maternal genital tract at around the time of delivery. It's rare, thankfully, because it is associated with significant morbidity and mortality. It manifests as disseminated disease in approximately 25% of cases, with viral sepsis, disseminated intravascular coagulation, encephalopathy, respiratory and hepatic failure. 30% manifest as central nervous system disease, and 45% manifest as skin, eye, and or mouth disease, which typically presents at about day 10 to 12 of life. The primary infection with HSV is often non-specific and passes unrecognised and undiagnosed. It doesn't often have the characteristic features that we commonly associate with HSV infection, as indicated in the pictures on this slide. Most commonly, it presents in a very non-specific, unimpressive way with blepharitis or conjunctivitis, and only very occasionally as keratitis. So for this reason, misdiagnosis and treatment delays of HSV keratitis are very common. If we look at case series, often 30% of cases are initially misdiagnosed, and there's regularly up to a 30-day delay to seeing a specialist. It's a challenging assessment. You know, children are upset and they can be difficult to examine. It's hard to see the characteristics on a slit lamp. And initial diagnoses might include viral conjunctivitis, blepharokeratoconjunctivitis, flictennular keratoconjunctivitis, or corneal abrasion. HSV keratitis is classified according to which layer of the cornea is involved. So that's the epithelium, the stroma, or the endothelium. The stroma is further subclassified as to whether there is involvement with or without ulceration. If the epithelium is involved, it's through direct infection of corneal epithelial cells, and it can manifest as the classic dendritic ulcers or also as geographic ulcers. 70% of affected individuals will experience corneal nerve damage, which will manifest as reduced corneal sensation, neurotrophic keratitis, and these things can all contribute to corneal scarring, particularly in children. Stromal keratitis in children is more common than in adults, and it's often associated with a really severe inflammatory where there is no epithelial ulceration, it's thought to be due to an immune-mediated reaction to the viral antigen, and long-standing or recurrent disease can result in neovascularization and even lipid keratopathy. Where there is epithelial ulceration, it's thought to be due to active viral infection, and recurrent or even a severe first episode can cause corneal thinning and corneal perforation. Endothelial keratitis is the least in children, and it often occurs independently of the other forms. Typically, it presents with a disc-shaped area of corneal edema, but it can also be diffuse or even linear. The sequelae are well known to us all. So the complications of HSV keratitis in children are namely corneal scarring and opacification, corneal vascularization. It can result in induced astigmatism, and all these things, of course, can affect vision either directly or through amblyopia, to which children are vulnerable. If we look at a table of recent series involving children aged under the age of 16, then we can come to understand that they are more vulnerable to visual morbidity because they're more likely to experience stromal disease, bilateral disease, and to also experience recurrence. We know from the HEAD studies, which looked at a very large population of individuals aged 12 years and older, if we know that the incidence of stromal disease is about 16%, whereas here the stromal disease is much more common in children. And of course, if the disease is stromal, then people are vulnerable to corneal scarring and astigmatism. With bilateral disease, the frequency reports in children are between 0 and 26%, and in adults they're up to 12%, so again more common in children. And the big risk factor in children for bilateral disease is atopic disease or associated systemic disease. And with recurrent disease, the frequency reports in children are between 33 and 80%, whilst in adults in the HEAD study it was 32%. You can also see further down in the table that really high numbers of children experience corneal scarring and induced astigmatism, and this manifests in, again, significant numbers having a reduction in their best corrected visual acuity. There's many investigations we can do to confirm or deny a diagnosis of HSV keratitis, but they all have their limitations and disadvantages. The most commonly used would be viral PCR, which is sensitive and specific, but it really does have a limited role in stromal and endothelial disease because you just don't get a sample on a swab. And really importantly, its role in delayed presentations is also limited. And this is significant because, as we've just seen, there's up to a 30-day delay in presentation to ophthalmic care or to specialist care. So other investigations that might be available are viral culture, but this has low sensitivity and it takes over 10 days to get a result, so really not practical in a clinical situation. Direct fluorescent antibody testing, which again is expensive and not widely available. A viral smear, which requires tissue scrapings, which is really not something that can be easily done in children. And serum antibody testing, but of course that doesn't distinguish active from past infection. So they all have their limitations. In terms of treatment, there are no large randomised controlled trials to help guide our treatment for active disease and also for prophylaxis in children. So really the current guidelines are an extrapolation of what we found in the HEAD study. An important point is to note that children are much more likely to have disease which is resistant to topical and systemic treatment. In Sydney, many of us carry this little treatment guideline you can see on the slide at the moment attached to our hospital lanyards. This was published by Stephanie Watson's Cornell unit, and she's published a really nice summary of recommendations for how to treat herpetic eye disease, and this is available online through the Save Sight Institute website. In summary, we don't use valacyclovir in children under the age of 12. Our first line treatment is acyclovir, but of course that's going to differ country to country. I know that in the States often they'll use ganciclovir as the first line, but our first line choice is acyclovir. For epithelial disease, then the recommendation is to use either a topical or an oral antiviral. Of course, there is toxicity issues associated with topicals, so where tolerated and where possible, I tend to go straight for an oral antiviral medication. Where the disease is stromal, again, the recommendation is to use an oral antiviral, initially on a treatment dose and continuing on a prophylactic dose whilst ever the patient is on topical steroid. And a long taper of a topical steroid is required to really moderate that risk of corneal scarring and induced astigmatism. For endothelial disease, an oral antiviral again is recommended, and similarly with a treatment dose and then continuing with a prophylactic dose whilst on topical steroid. Prophylaxis, which should be used for at least 12 months after the last episode, should be considered where there are episodes of multiple recurrences, particularly involving the stroma, where there's recurrent inflammation threatening the visual axis, after penetrating keratoplasty for HSV or any other kind of eye surgery, or where a child has developed ocular HSV whilst immunosuppressed. The dosing is pretty simple. Less than 2 years, you'd use 100 milligrams 3 to 4 times a day, and over 2 years, you'd use 200 milligrams 3 to 4 times a day. And it is important to consider that as children grow and gain weight, then they may fall out of a therapeutic range, and that can result in recurrences. So it is important to check their prophylactic dose as they grow. So HSV keratitis in children has worse outcomes compared to adults because they're difficult to examine, so it can be really difficult to actually make the accurate diagnosis. There are higher rates of misdiagnosis and treatment delays. Children often experience a more aggressive disease course with more frequent bilateral disease, more frequent recurrences, and stromal disease being more common, which of course is high risk for vision loss. They also have a higher chance of demonstrating resistance to topical and systemic medications. And of course, they're susceptible to corneal scarring, and their age makes them vulnerable to amblyopia. I'm just going to finish with a short case, which demonstrates some of the difficulties and complexities in making and confirming a diagnosis of HSV keratitis. So this is a 6-year-old female patient who was well known to our department, and she presented between scheduled appointments with a 4-week history of left eye redness and mild irritation, and also her mother reported seeing an unusual spot on the front of the eye. This patient had a history of multiple chalasia, which had onset at the age of 6 months, which had all been managed medically. She had a history of mixed blepharitis with keratopathy and was on medical treatment for these. And she'd previously required systemic erythromycin and azithromycin for management of her blepharitis. She had a history of an anisometropic amblyopia of the left eye, for which she was wearing spectacles full time, and was also undergoing part-time occlusion of the right eye. At presentation, her right eye vision was stable at 6/12, so in keeping with her previous measurements, but the left eye vision was reduced to 6/48. She did quite well at the slit lamp examination. Her right eye examined normally. In the left eye, you can see here she had a central, quite large corneal opacity, which involved the epithelium and the stroma. She had an overlying epithelial defect. She had significant corneal neovascularization with vessels extending across the inferior limbus and towards the central cornea. There was no uveitis in the anterior chamber, and her dilated fundus examination was unremarkable. So my thoughts on the differential at this stage were staphylococcal keratitis or HSV keratitis. And I've written up my for and against here. So with the long history of blepharitis and chalasia, your first choice, of course, might be staphylococcal marginal keratitis. But it's uncommon for corneal infiltrates in the context of staphylococcal disease to be central. They're more likely to be at the 2, 4, I've written 5 there, sorry, but 2, 4, 8, and 10 o'clock positions. And it's also more common for that condition to be bilateral, not unilateral. And at present, this child had quite good control of her blepharitis. So because it was unilateral, because it was central, because there was stromal involvement, I thought it was more likely to be HSV keratitis. We did an HSV swab and it was negative, but look, that didn't really put me off, because you'd recall that there was a 4-week history prior to presentation. So I'm not at all surprised that that came back as negative. I thought on the balance of things, this child was much more likely to have HSV keratitis. I also thought that if I didn't treat for it and it was HSV, then she was going to have really significant visual outcome because of that stromal involvement in the central location. So I treated our patient with acyclovir 200 milligrams 5 times a day for 2 weeks, along with topical Ocuflox and Maxidex, and we continued lid cares and patching. I was pleased that after a week, her vision was improving and the epithelial defect was significantly smaller, and the lesion was becoming much quieter. The vessels were shrinking nicely. At the 2-week mark, her vision was improving further. The epithelial defect was fully resolved and she had just ghost vessels crossing the limbus. And at 2 months, her vision had improved to its baseline of 6/12, and she had a residual corneal scar and ghost vessels, and we're continuing to manage her amblyopia. So thank you very much for your attention. Okay, now if anyone has a question, please feel free to type it into the question and answer box. If I could have the speakers come off mute, and while we're waiting for other people to potentially ask questions, could I ask a question of you, Dr. Huang? You spoke about augmenting a bilateral lateral recession of between 1 and 1.5 millimeters. How do you choose whether to do 1 or 1.5? Or if your baseline recession was 5 millimeters as opposed to 9 millimeters, would you do less for 5 and more for 9? Could you give me some guidance as to how much you would augment, or is it a personal preference?
At first, can you hear me?
Yes.
Can you hear
Yeah,
me?
you are audible.
Okay. At first, I started to add the 1 millimeter because I'm kind of very nervous to further overcorrection. But as I do the 1 millimeter more recession, instead of overcorrection, undercorrection, there were so many undercorrections, even with the 1 millimeter augmentation. So now I am adding 1.5 millimeter more to the Dr. Park's formula. So I think that the 1.5 millimeter might be relatively safe, as well as very effective for the surgery. And the is that for your did I answer your question?
You've answered it perfectly. Thank you so much. Yes, thank you. Yeah.
Thank you.
Dr. Hwang, I would like to ask, do you use routinely prism adaptation test in cases of intermittent exotropia preoperatively?
In case of exotropia, I usually do not do the prism adaptation. I only do for esotropia. Thank you.
Dr. Huang, you said you increase amount like 1 or 1.5 millimeter. You mean for each muscle or for total amount?
Yes,
For
each muscle. Yes.
So for instance,
so the both muscles. So I add 1.5 millimeter for each lateral rectus. So that would be, yeah.
Okay, so for instance, if the patients have like a 25 or 30 present diopter at distance at prime gaze, and how much would you resize the bilateral BIR? You do BIR for 7?
I usually follow the table in the operation room, so I cannot remember the exact number, and later I can send you my table and the augmented number.
Wow.
That's
nice.
the usual one for the Dr. Park's formula, and I just add 1.5 millimeter more.
Okay, because in China, every surgeon have the table just in map. But I heard that some American doctors, they just go to the operation room.
Yes.
And put the tables on the wall.
Yeah.
Right.
I have
And
okay.
Secondly, Dr. Hwang, do you routinely use pre-op patching in cases of all cases of intermittent exotropia, and for how much time?
I always treat the amblyopia first, and after
No, it is not regarding question related to amblyopia. For finding out the maximum deviation, we do the patching to know the maximum angle of deviation. So, do you routinely do prior to surgery?
I usually do if patients show the divergence excess type exotropia, I routinely do the preoperative monocular occlusion that may reveal the true near angle of deviation. So I usually do that, but
it is very important to know. Otherwise, there will be undercorrections.
Yes, right.
Yeah. And you use for 2 hours occlusion or 24 hours occlusion?
Pardon?
How much time of occlusion do you use? You use 2 hours or 24 hours?
I usually do the 1 day patching.
24 hours.
Okay. Yes.
Okay. And now I think there is question in the chat box for Dr. Caroline. Dr. Caroline, you can reply the question.
Yes, I've got a question from Nazli, which I
So
I don't fully understand it. I've asked that doctor to rephrase it. Yeah, I've asked them to rephrase it. I don't fully understand the written question. I apologise, but please.
I think there are two questions for you. One you have replied in the chat box. So that is regarding, do you add artificial tears for all type of HSV keratitis? So your answer is yes, I often do. I use a preservative-free lubricant.
Yeah, that's right. So I think wherever there's any keratopathy, then if there's any keratopathy, then I do use it. I use it quite frequently. Of course, there are challenges with using drops frequently in children, but I do recommend it. The other thing I'll do is speak about using a preservative-free drop more frequently, or a gel or an ointment less frequently, and give the family the choice, but I always recommend something preservative-free.
And how common is recurrence in your set of patients?
How common is recurrence?
How common is this recurrence of HSV keratitis in your set of patients?
I've got a couple of patients on prophylaxis who've had central stromal disease, and I haven't had any patients recur on prophylaxis. In those series that I presented earlier, 80% of children get recurrence within 13 months, so it's very high. And then there's even a proportion of children who recur on prophylaxis. That can be just because the disease is very aggressive, or because the children grow and put on weight, so even their prophylactic dose becomes subtherapeutic, or because of associated illness. So they'll have a diarrheal or a gastrointestinal disease and they won't absorb their medication, so they become subtherapeutic. I've got a question for Professor Sito. What age would you recommend electrophysiology in a child who is systemically well and who has a perfectly normal ophthalmic examination apart from delayed visual milestones? So where you're thinking this is likely delayed visual maturation, at what age do you recommend or suggest investigations such as neuroimaging or electrophysiology?
I usually recommend electrophysiology for those decreasing visual acuity in baby with the presence of nystagmus, because I consider hereditary retinal dystrophy at that case. We know that in hereditary retinal dystrophy, the baby showing no, in addition to the decreased visual acuity and nystagmus, but we cannot find any abnormality in the anterior segment, and oftenly also in the fundus, because no pigmentation and no retinal pigmentation bone spicules at that time. The bone spicule will be developed at first decade of age. So in this case, would be better. It would be suggest to do electrophysiology to confirm the diagnosis, the possibility of hereditary retinal dystrophy group.
Thank you. Does anybody else have any questions they would like to type into the box or ask panelist to panelist?
There is no other question in the chat box.
I would say the talks were so perfect and well explained that no more questions, I would say. All the points were explained clearly. So I would like to take this opportunity on behalf of DOS. I would like to thank all the speakers for giving us their valuable time. And I would request Dr. Subhash to give the closing remarks for this session.
So I would like to thank the Asia Pacific Society of Paediatric Ophthalmology and Squint for agreeing to participate in International Dose Virtual Conference. And I would personally, being a strabismus surgeon, would personally like to thank all my colleagues, international colleagues, for sparing their valuable time and clearing the doubts from the mind of audience. And thank you all the speakers and all the delegates. Please take care and stay safe and healthy. Thank you.
Thank you very much.
Thank you very much.
Yeah.
Bye.
Bye. Thank you so much.
Bye.
Hi.
For all the attendees who are still watching, we shall be logging back at exactly 6:30 Indian time. Thank you so much for your patience and being there with us. Thank you. Take care.
Thank you.
Recording paused. ठीक है.
जी
खाना खा लिया अभी.
हाँ खाने जा रहा था.
सवाल सब डिलीट कर दिया तो हो गया सब शांत. मिलते हैं वापस.